Hi everybody, we're going to take less than an hour for a 35,000-foot view of cardiovascular disease. How it starts, how you might be able to spot it in the field, and some things you can do about it, although sometimes it will be just transport. Hey, I'm Chris Livingston, and my qualifications are I'm a paramedic. I work at Scotland County EMS for almost 3 years now. I'm firefighter 1 and 2. And I hold a MS in biomedical research from Wake Forest University and BS in biology, summa cum laude from Fayetteville State. And this is for my EMS instructor class, but I'm going to put it on my YouTube channel that is Super Spike Science, and anybody can watch it. Suitable for all audiences, by the way. Anybody from emergency medical responder to critical care paramedic will get something out of it. All right, so CBD, here's where you can find it. That is anywhere you have cardiovascular items in your body, like hearts or vessels or anything of that sort. They're non-communicable diseases. I don't know of any that are communicable, but as far as I know, everything is non-communicable. That is, you kind of pick it up yourself and couldn't give it to anybody else. And CBD kills more people than anything else these days, more than starvation, because people are following our bad American habits and being too overweight and eating too much sugar and smoking too much, drinking too much, and stressing too much. We do run into these in EMS all the time. I work in a rural area that's not real wealthy, so we have at least our share of CBD. And in the field, sometimes we can help, and sometimes we can't other than transport. So we'll take a deep dive here, or medium dive, and try not to bore you to death, but I do want to elevate your knowledge level. So let's go. Some examples we see. Ah, yes, of course. STEMIs are to medics what drunk drivers are to state troopers. That's what we look for. The worst kind of heart attack that is a STEMI, it will show up on a 12 lead, but if it's not, it could be an NSTEMI, still very serious. STEMI usually requires for the infarct, that is the dead part of the heart muscle, to burn through the entire heart wall so that that's when it tends to show up. But in STEMI, that means it hasn't gone through the entire heart wall. AAA and dissection, not often seen, but when we do, it's serious. ACS, yeah, that's also common. It can happen, that can include stable or unstable angina. That is, stable angina only happens when you're exercising, and usually means that you got some ischemia somewhere, that is, your heart's not quite getting enough oxygen. But unstable angina means it just happens. You just have chest pains out of nowhere. And stroke and TIA, we do see this. Thankfully, most of the time a stroke is called in, it turns out to not be a stroke or even a TIA. But sometimes it is, and we're part of that. Well, they call it the golden hour. There's not really any evidence for an hour exactly being important, but the idea is to get your patient to the hospital and to the CT scan. That is the donut of truth. All right, heart failure or congestive heart failure. We do also run into that. And it can, again, we do know by now there's a difference between heart failure and cardiac arrest, which is, I mean, heart failure can lead to arrest eventually, but they're not the same at the moment. Pulmonary embolism. That's when a blood clot gets stuck somewhere in your pulmonary artery. It's not common and often mistaken for other things, but something we got to take into account. So how it starts is something called atherosclerosis. Now, hardening of the arteries in general is called arteriosclerosis, but atherosclerosis, that's what they called it when they first gave it a name, and it's nothing new. I mean, these things have been found in Egyptian mummies, for Pete's sakes. And you don't have to be super old. In fact, in the Korean War, Vietnam War, some soldiers that were killed when they were very young, 20s or even teens, turned out to have these lesions upon autopsy. We'll go into a little more detail. And it's not just bacon grease building up on the inside of a pipe. That's pretty complicated. And you'll see from the figure, see if you can see my arrow. And Thomas starts out pretty good, builds up some plaque, builds up some more plaque to where there are necrotic areas inside that is dead cells, and eventually can rupture and cause blood clots exactly where you don't want them. Arteries, they are pretty complicated, more so than veins. They come in layers, and you have outside an elastic membrane called the adventitia. In the middle, you got 3 layers of tunica. That is, you guessed it, the externa, the media, and the intima. The media is mostly smooth muscle. That is, you can't control it yourself consciously. And the intima is an elastic membrane, also called the endothelium. And miraculously, the endothelium allows blood to flow through arteries without clotting. Now, you think that's nothing special? It is extremely special. Blood really just wants to clot. It just wants to sit there. But you needed blood flowing to stay alive, so your arteries help you do that. And when we keep whole blood stored, we have to add all kinds of anticoagulants, I believe, and keep it refrigerated and all this, but your arteries just do their thing without even trying. All right, atherogenesis. Here's another view. Nice round artery here, but what do we got? Some small fatty streaks you can barely see. Now, these aren't too complicated, and this stage can pretty much be, sometimes it will keep going, sometimes it will slow or stop or even reverse on its own, or because you decided to do something about it. Do not smoke. I'm going to say do not drink. We don't know if there's any safe level of alcohol consumption. I mean, drink once a year at a ceremonial occasion, that's probably safe. Drinking regularly, ethanol, I'm sorry kids, is a poison. Its first metabolite is something called acetaldehyde, which is pretty clearly a carcinogen. That is, it causes cancer. So it's best to just stay away from it, or just to moderate it as much as you can. Obesity, yes. When you weigh too much, you tend to place a lot of strain on your blood vessels, starts building up high blood pressure, and it's just generally not good for you. Low exercise. You need to get out and get your exercise, especially more and more evidence is piling up. Weight training, that is strength training. Yep, go to the gym and pump some iron. If you can't get to the gym, try and keep some iron in your house. This is not an exercise video, but there are ways to build your strength. And that's just something that, even more than cardio, has been shown to head off aging, and especially osteoporosis, which women tend to get more than men, but some men have it. Genetics. Now, that's something we can't do a lot about. You might have an extensive family history of heart trouble, and you might not. Some ethnic groups, African American, Native American, it's unfair, but heart disease does discriminate. So more so than the average person, if you have a genetic history of heart trouble, atherosclerosis, anything like that, stay on top of it. DM, diabetes mellitus. As you probably know, sometimes we're born with it, and it shows up early in life. That's type 1 diabetes, which shows up as an inability to make enough insulin. Later in life, it could be type 2 type 2 diabetes, which means we've all seen the commercials about how you're resistant to insulin. And in time, you can need insulin even with just type 2 diabetes, because it will cause more and more damage, including your beta cells in your pancreas that make insulin. So sometimes type 2 diabetes persons will need insulin. And hypertension, yeah, hypertension, you can't feel it, but it is damaging your organs. And you just keep on going until one day everything is not all right. Oh yeah, the SAD. That is seriously what we call it in scientific research. The standard American diet. A lot of sugar, a lot of calories, a lot of fat, a lot of processed foods. Uh, these all feed some forms of inflammation. That is irritation. I mean, inflammation is great when you're got an acute injury and your body is healing itself, but not so great when it goes on all the time. It can become something called metaflammation. That is metabolic inflammation that's just there all the time and isn't doing any good whatsoever. All right, these lesions start out, yep, as we see, as tiny fatty streaks, and it's not necessarily going to keep on that way. And how does it grow? That is, all these lesions. And I'm going to try not to bore you stiff here, but you can also, if you want this PowerPoint show, I'll be glad to send it to you, and you can look at it much closer. So as inflammation irritates and starts processes that shouldn't be starting, you're going to get bigger and bigger and more complicated lesions. Now, high blood pressure contributes by kind of mashing the inner lining and also stretching it in ways that it wasn't intended to be stretched. And you'll let in LDL cholesterol. We probably know that's the bad cholesterol. Sensor cells then kind of send the wrong signals to grow the wrong things the wrong way, and you start to get lesions. And even though it's not, we're pretty sure it's because the flow gets turbulent and not just because it gets slow enough to just precipitate things out of solution. But we do have lesions forming where flow is disturbed. Like here we see it's at a curve or at a branch point. And over time, you build up a necrotic core of dead cells, and that in time can rupture. So having a higher fat diet is a little controversial because you can be on keto, maybe because you have seizures, and still be pretty healthy. But too much sugar, that isn't. I mean, think about it. If you drink one 20-ounce soda that's full of sugar, that's pretty much your entire amount of sugar you should have for the entire day. And we're talking added sugar, that is sugar we put into things, not the sugar that naturally comes up in fruit because we know how to handle that. But added sugar, yeah, you gotta watch those food labels. All right, how did I pick on this? All right, I admit it. It was my thesis topic at Wake Forest. There's your cover. What we did is look at a way of finding atherosclerosis early on. This is molecular biology. You can look at certain types of control molecules we call microRNAs. Probably heard of RNA. It's the messenger. I mean, it's how DNA communicates with the rest of the body. These are really crucial metabolic regulation tools, and they're discovered in about the 1990s, and they won the Nobel Prize. We didn't realize that this is one way that pretty much every life form controls itself. Baboons, they were kept in Texas as part of a long-going project. There are about 100 odd of them that were fed each diet, and every single one over 2 years that were fed the SAD turned up with coronary artery disease. And then they were euthanized and their blood levels measured. So if we got too many of one type of microRNA or too few of other types of microRNA, that could be an indication that something's going wrong. Was it successful? Well, sort of. We found that some microRNAs were coordinated or correlated, but we couldn't prove cause and effect. And with some statistical tests, it just didn't hold up. But I think we're onto something here. That way, if we can work this out, we just have a simple blood drop test, just like taking blood sugar, to see how your atherosclerosis is doing. I wish I could send you a copy of this, but because it has some proprietary data in there, it's been embargoed for the next few years. hopefully we'll release it at the end of that. All right, so EMS things we see. We already have billions of how to run a code videos, including mine, which might not be the best, but it's definitely the only one you really should see. And we're not going to get too much more into science papers. I did use some as references, and we'll have the references at the end of the slideshow, and also in the footnotes to each slide. It's also where we get the image credits. But if we get out of control, please bear with me. It won't last forever. Now, H's and T's, we've heard that. Here is the official American Heart Association adult cardiac arrest circular algorithm. Way down here at the bottom, that's where you have your list of H's and T's that you've probably gone over when there are 25 people in the back of the truck when you're running a code and you're trying to figure out what's wrong with your patient. Hyperglycemia is not on there, although sometimes what looks like a cardiac arrest really is hypo, especially glycemia. I mean, how many times have we started attaching pads and started doing CPR, and finally somebody remembered to bust out the glucometer, like, oh, blood sugar's 20. I guess we should get in some D50. And when you have really any kind of unconsciousness, falling down, weakness, can't figure it out, see, blood sugar might have something to do with it. The H's, they all start with an H, except for acidosis, which involves hydrogen ions. That starts with an H, but okay. We'll still say it starts with an H. Usually it's hyper or hypo amounts of things. First one is hypovolemia, not enough blood. What can we do about it? Of course, we hang saline or ringers, which adds volume, but not red blood cells. And if you have ONEG, wonderful. We do not at our service. It's just rarely needed and requires refrigeration and a protocol. And usually you just have 1 or 2 units that are kept in the QRV, which might or might not be able to get there in time. But this is from the National Highway Traffic Safety Administration, which somehow became the government agency that kind of oversees EMS and EMS aid. So that's their little poster on how you can start your very own blood transfusion program. And it really does improve survival when it works. But how do you get too little blood? Sometimes it's external bleeding. We can often, if not usually, stop that with tourniquets, dressings, and whatnot. Internal hemorrhage, we cannot stop that. That's a trauma surgeon thing. Busted spleens, these do happen in motor vehicle accidents, and they will be leaking blood. And again, that's a surgical emergency. If you have a ruptured AAA, that can kill you in minutes. We'll get to that in a little bit. Hypoxia, don't have enough oxygen getting in there. So here's our capnography waveforms from pretty good to not so good to really bad. A sticky up shark fin, bad. You can usually fix it just by adding some oxygen, and if you have blood loss, especially gunshot wound, stab wound, you will need a non-rebreather. You got suddenly much fewer red blood cells than you had before, so you need to pack out with all the oxygen you can, the ones you got left. Airway, yeah, check on that. ABCs, but we know usually before that X, ABC. X for exsanguination. Got to address that or your airway won't matter. Check your placement for your tube or your blind insertion airway device. Some of us are so old we still automatically say King, even though King is fallen out of favor lately. Usually we use eye gels. If you got a tube in, make sure the cuff is inflated correctly. Oh, what is hypoxia? What is hypoxemia? First you have hypoxia, which can be just the whole body's not getting enough oxygen, or it can be certain tissues not getting enough oxygen. So hypoxemia, that's easy. You just look at your pulse ox. That means if it's low, then you got hypoxemia. And that can develop into hypoxia. Also, the best way of checking to see if your tube is incorrectly is, did it go through the cords? I mean, you can do end tidal, you can do x-rays, you can do breath sounds, but did it go through the cords? Yeah, that's what it's got to do to start with. Here we go. Acidosis, hydrogen ion. Yep. That's a stretch. hmm. Have we discovered the cure for acidosis? Just warm blankets? Well, no. But it helps. Strong triad of death. We got hypothermia, plus coagulopathy, plus metabolic acidosis. Your warm blanket might be able to help with that. And HSNTs are reversible causes of cardiac arrest. How can we do that in the field? Kind of tough. A lot of people like to give sodium bicarb, especially toward the latter stages when you're about to call it and you have no more ideas, really. But it is not indicated. It did used to be on the protocol, but it is not anymore for good reason, unless you suspect an overdose of tricyclic antidepressants, which we don't often see anymore. Elavil is one I can think of. But they are still around because sometimes the first line choices don't work. Hyperkalemia, that can help. Keep your patient warm. All right, you got DKA when you got Kussmaul breathing and you got sky high BGL. Fluids don't reduce blood glucose level. Sorry, kids, they just don't. Only insulin, exercise, etc. does that. Why you hang your fluids is for rehydration, because water is being sucked out of the blood and into, out of cells and into the blood, where it doesn't really do any good. All right, more about when you do use bicarb. All right, here's your nice EKG. Again, we'll be glad to send you this figure. It shows progress of, here's your normal complexes. Here's hypokalemia. You might get an inverted T wave instead of peaked, and you might get depression here at your Q point. Then there's early or low hyperkalemia, peak T waves. I think of a letter K sitting on top of peak T wave. Here's gets even more peaked. And here, well, it just looks like Twin Peaks. So if you start seeing this ST depression, shallow T for a hypo, it is associated with DKA and with chronic kidney disease and dehydration. That hyperkalemia, got your peak T wave, might have a long PR interval. That can cause bradycardia. So if you got crush syndrome, that is somebody's arm got mashed in a machine or mangled in an MVA, you're going to have a lot of crushed cells and potassium leaking out of them. If you know why it says K, Latin word for potassium is kalium. So that's why we say K. And dialysis renal failure can fill you much too full of potassium. Here's where you use the bicarb. 50 milliequivalents, that's what we usually have in the vial, or the syringe rather. You probably got calcium chloride too, or calcium gluconate. I think our service carries calcium chloride, but you'll need a separate line for that. But the big thing is get your sodium bicarb in there. Hypothermia. You don't have to be frozen solid to be hypothermic. This is your body temperature scale, 98.5 for 6. Usually when I take patients' temperatures, it's really about 98. But when it gets down to 95%, or rather degrees Fahrenheit, that's starting to get into trouble. Below 90 Fahrenheit, it's severe. You got especially hypothermia can have a disproportionate effect when you already are suffering from trauma, or you had a drowning victim that's been in especially cold water, and now you bring them out into the atmosphere, and the water starts evaporating and makes them even colder. You got infants or children, and you got seniors. They're especially susceptible. Burn victims, even sunburn, can damage your skin bad enough to where it doesn't work nearly as well as it did in controlling your body temperature. And oh yeah, alcohol and drugs can really affect your ability to control temperature. You remember the old cartoons with the Saint Bernard running out in the snow with a keg of brandy? They used to actually think that helped, because when you drink it, you feel warm. But we found out it's the exact opposite. It's preventing blood from getting out there. It makes you worse. So you can count on seeing an altered mental state and bradycardia. So you need to give a pulse a full minute before saying that they are pulseless. So even when it's pretty hot outside, you need to cover your trauma patients with a sheet or a blanket. Uh, Hypothermia, active warming measures. You got heat packs put under the arms. Turn up the thermostat in the truck. I mean, we can make it into a 100-degree neonatal unit if we want to. So I know you're hot, but that's okay. We got to serve the patient first. And here's what it says in the state protocol. You're not dead till you're warm and dead. So don't call it until you've warmed them up and see if that improves anything. Now, when you get ROSC back, there is a lot you hear about targeted temperature management. That's really a hospital thing, probably not in the field. Some services with long transport times may want to look into it, but you'll need a reliable measure of taking core temperature, at the very least a rectal thermometer, and a way to control your hypothermia. So it's probably a long time coming to EMS. Now here comes some things that start with T. There are several different types of shock. Here we have obstructive shock. That is something is messing with the heart, preventing your heart from fully pumping. Tamponade tension pneumothorax can do that. So can aortic dissection. We'll show how it can. Clots can get in there. Thromboses, that could be heart attacks. Toxins. Oh yes, opioids. Sorry, I've got a bit of bronchitis here. Obstructive shock. Tension pneumothorax. First, we'll show you. Here's where you put the dart, either here or here. And please, if you have one, use an actual pneumothorax kit and not just use up those 16 gauges that are about to expire. It's something you really got to look out for. Chest trauma. We've got fractured ribs, flailed chest. Everybody hears, oh, your trachea is going to be off to one side. That's actually a late sign. You should be doing something about it by then. Again, use the actual dart that you have in, should be on the jump bag on the side pocket near the trauma stuff. IV catheter might not reach, but if that's all you got, go for it. Cardiac tamponade. So here's what it looks like. You have the heart in a pericardial sac. It actually floats in there. Now, a pericardial sac is like a plastic chopping bag. It doesn't stretch. It's designed to not give, so that you got a constant pressure and amount of fluid to where your heart can just float and do its twisty ring out thing with every beat. But if you got too much fluid, then heart starts to not be able to hold its shape. The disease process might let fluid in steadily over months or years, but trauma can flood your heart pericardial sac with too much fluid. Beck's triad. Anybody remember, say, the tetralogy of Fallot? Me neither. Maybe we can remember 3 things, not 4. So if you got JVD, that is jugular vein distension, big neck veins, and you got hypotension, and you got heart sounds that are barely hearable, then you probably got cardiac tamponade. You also might hear the patient will start to become shorter breath, and you might hear decreased breath sounds on the side that's most affected. So this one, I don't think we're going to be doing pericardiocentesis ourselves anytime soon. It might be tried, but really need hospital transport, and they'll get the fluid out. Aortic dissection. This is bad, but not as bad as a burst aneurysm, but still bad. So the aortic dissection is different from a burst aneurysm in that you got, I don't know if you can see it, it's just a teeny little opening here on this diagram. So we got high pressure blood in the aorta, and it starts to work its way in there and slowly or quickly disassemble your aortic layers. Now, the blood doesn't generally burst out of the aorta. It just kind of collects in a pool there, out of circulation. So usually not enough to cause hypovolemic shock. But what does happen is as more and more blood uh, rips its way through the intima and then the media and then close to the adventitia, that's called dissection. And it might proceed slowly or it might proceed quickly, but as you see, it's starting to enlarge and you're right next to the heart, so you can compress your heart enough to where you get obstructive shock. And that, again, is a surgical emergency. Toxins. Ever wonder why we carry all these calcium chlorides and sodium bicarbonates? Because they can work against um, certain toxins. We got opioid poisoning. Yep, push Narcan. Instead of pushing bicarb as the last resort, try to push some more Narcan. Organophosphate poisoning. Everybody thinks nerve gas, terrorists, but you know what? It can be if somebody just happens to be in a field that's getting sprayed with pesticide, and either the pilot didn't see them or there was some miscommunication. But if you start breathing in pesticide, that can give you organophosphate poisoning. Atropine, you might or might not carry enough on the truck, but start giving some. I think we carry a total of about 6 or 8 milligrams. You may need more than that. Toxin could be a prescription drug you're supposed to be taking, but you have too much of it. Heart drugs actually are bad about this. Amiodarone, it's supposed to be an antiarrhythmic, but take too much of it, or when it's not indicated, you could have a proarrhythmic. Tricyclic antidepressant again. Sodium bicarb, and the P dose is 1 milliequivalent per kilogram. Bradycardia. Too much beta blocker and too much calcium channel blocker. Cardizem, diltiazem, or verapamil overdose. That you might have to pace even. But first, let's try some glucagon. That's the other thing glucagon does. Calcium gluconate, if you have it, and P dose or calcium chloride. And there's your dosages. But please look up the state protocol. This is, by the way, most of my sources are the state protocols or scientific papers. This is straight from the state protocol. At our service, we pretty much go state protocol. Your service may be more aggressive or a little more conservative. It just might be snake bite. Probably the patient will let you know if they think they've been snake bit, but sometimes you can get tagged with one fang and not even know it. There's an extremely outside chance that you might even have somebody who got bit for the first time in 50 years by a coral snake, which has a neurotoxic venom, and they might be in shock already. I hope not, because I don't know if they even make that anti-venom anymore, and the dose takes like 30 minutes to reconstitute, so just don't get bit by coral snakes. Thrombosis, pulmonary, or an embolism. Now, this may take a while to travel before it gets to an arteriole that's small enough to get stuck. But it starts as a DVT, and it breaks loose, rides into circulation, comes in up through the inferior vena cava, or IVC, up into your pulmonary arteries. And if it happens to get stuck, then that's pulmonary thrombosis. It can cause shortness of breath, chest pain, even syncope. Might show up as the famous S1Q3T3 on your 12 lead. We get to that. I think that'll be our last slide. And it could cause cardiac arrest. Well, a lot of other things cause these. So diagnosis is a hospital thing, and even they might or might not get it right. Hopefully they will. We got more and more tools, more and more collective wisdom. But we are unlikely in the field to be able to conclusively say, yep, you got a PE. So get to the hospital. Coronary thrombosis, aka myocardial infarction, heart attack. You ever wonder what exactly is a heart attack? Well, just go to the American Heart Association. They got a fourth universal definition, 34 pages. They will define a heart attack in excruciating detail. Generally, it's caused by an atherosclerotic lesion, rupturing and leaking clotting factors in your bloodstream. And if that's in the coronary artery, you got coronary thrombosis. You might not even know you had a heart attack. We think there are more and more of these than we ever thought. And you don't even know until much later somebody does a 12 lead or you get on a treadmill, like, oh, dude, you used to have a heart attack. Well, you can also just get acute coronary syndrome, of which heart attack is a part. And as we all know, if you have too much heart muscle die, then you're going to not be able to live, really. So aspirin, which is not a clot buster, it's not even a blood thinner, it's a platelet inhibitor that can help stop more clots from forming. And that's about the only thing we know in the field that does work. That and a quick trip to the cath lab. Some other CVDs, again, often we can only transport. And sometimes we can counsel folks to say, hey, you need to change your life. Now, the official story from the American Heart Association is systolic blood pressure between 120 and 130 is pre-hypertension, and over that is stage 1, 2, 3 hypertension. Some say that's not really harmful. You're just trying to sell blood pressure meds. Well, maybe, but let's keep it down, you know. Have we ever wondered? I mean, the low blood pressure, we all know that's bad. High blood pressure, you will get patients with blood pressure. They'll get in your truck, and every time you see them, they got 220 over 150. But that's not an emergency by itself unless you got some kind of headache, chest pain, dyspnea, altered, or seizure, or organ dysfunction. Some people will try to give nitro. Please don't do that. The hospital often will only just observe, but it will get you one of these days. This is something I tell to patients who keep on showing up with hypertension. If something can't go on forever, it won't, because you are doing damage to your kidneys, your heart, your liver, and you'll be okay until one day you're not, and we can't bring you back to life. All I can do is tell people we really like you, we really care for you. Please take care of yourself. I don't know if it works. I hope it does for some people. Well, a little bit more about heart attack. Here's your progression of acute STEMI. Again, this is not an EKG tech class. I've already taken one of those. I highly recommend it. You can take it at Robinson Community College. I think it's just a couple hundred for the book and 70 something for the class, so it's well worth it. Again, if you have a completely burnt through heart wall, then it'll start to show up as a STEMI. And it's usually due to a clot, but sometimes your arteries will just pitch off for whatever reason. I don't know why they would do that, but they do. And again, might be asymptomatic. You might see it much later on a 12 lead. And again, MI is not cardiac arrest. It's not heart failure, but it sure can lead to cardiac arrest. And it can lead to heart failure if it kills enough heart muscle to where the heart can't pump very well anymore. I know you're dying to hear about this. Pardon the pun. Very bad pun. AAA, abdominal aortic aneurysm. Might be a little hard to see this little diagram, but like any other aneurysm, it forms as a bulge, a weak spot that eventually can burst. If you do, now dissection, again, might not be an immediate concern, although if it's discovered, it needs to be addressed. AAA, once it ruptures, it's RAAA. You got half a chance of making it to the hospital. Even if you get to the hospital, your chances are slim. I'm sorry, that's just the way it is. The risk factors really are the same as any other, especially hypertension. Also smoking. That really weakens your blood vessels. Marfan syndrome is a congenital disease where people are really tall, got long fingers, they're really flexible, and so for the longest time we had great basketball players and volleyball players, and we thought, wow, they're so graceful, they're so flexible, and they're so tall, they're great at this until they die on the court at much too young an age because had Marfan syndrome. So they're better at screening for this now, but it um, it could be somebody that's really tall, really long fingers. Um, they're especially susceptible to this. All right, we've probably heard of stabbing knife-like pain. Based on at least one cardiology text I read, this only happens about half the time. If it is present, yeah, take note. But I did have one inmate that I picked up one day. He said, "Oh, I've had stabbing pain. It's like a knife." Like, really? How long? "Oh, it's been going on for a day." Oh, okay. So that's probably not a ruptured aortic aneurysm because those don't go on for days. I think he just wanted an evening on the town. TIA, ischemic stroke. Again, we run into suspected strokes quite a bit. They're usually not strokes, thankfully. TIA is taken too lightly. It doesn't leave damage, but it is a sign that you've got something wrong with your blood flow. You've got an occluded artery, and it's quite likely to cause any further trouble. Brain attack. Ischemic stroke means something's not, blood is not getting to an area of your brain. And as we all know, it's going to be on the signs are going to show up on the opposite side from the brain, from where the lesion is. Again, not a lot to be done with in the field. There is something called activase or TPA. We don't have that in our system, but maybe you have it in yours. So TIA, that happens. Look into it. Hemorrhagic stroke. This is one stroke in 6. This is really bad. Again, we got either an aneurysm in an arteriole, or something called an AVM. Don't have a diagram of it, but just imagine a ugly little knot of veins and arteries that aren't doing anything. That's just something you were born with, and it can bust at any time. Get you to the hospital. So hemorrhagic stroke, same as everything else. For older people, you can get something called cerebral amyloid angiopathy. Might have something to do with Alzheimer's. But once it does happen, you got a microaneurysm, it bursts, and now you got ischemia and also increased intracranial pressure. In addition to BFAST, balance, eyes, facial droop, arm droop, speech, time to call 911. You might have a thunderclap headache. You would think TXA would help, but it doesn't. And get an exact time because some meds they give in the hospital, you have to have an exact time and get to the hospital. CHF, it's really heart failure. We just don't like to say congestive. It's kind of redundant. That is, your heart isn't pumping enough blood. And again, MI that kills part of your heart muscle can get it done. It goes in stages and can be classified by how much blood can it still pump in terms of fraction. Pulmonary edema here, where fluid gathers in your lower lobes of your lungs, shows up as rales or crackles, and again you can have vein distension, cardiomegaly. Minor criteria, you'll have edema in your feet, pitting edema, where you mash it in and it stays pitted, shortness of breath, fatigue, and high heart rate. Oh, thank the Lord for CPAP. Produces preload, produces afterload, push fluids out of lungs, can't beat it, except for patients who can't tolerate it. Do a 12 lead because you might have more than one thing going on, not just heart failure. Lasix, we used to think it helps. It doesn't. Sublingual nitro, if your blood pressure is over 100 and you haven't had any Viagra or Cialis for the previous day. Paste, I've never used it. Some people think it just should go in the trash, but maybe you know how to use it correctly. If your blood pressure and heart rate are up, you can do CPAP. Discontinue if the patient goes into cardiogenic shock and go to your shock protocol, which is AM5. All right, here's your S1Q3T3, the one you can't ever remember. So you got S1, prominent S wave in lead 1. You got a prominent Q wave in lead 3. And you also got inverted T wave in lead 3. Now we probably were told, oh, that means you got a PE. Well, it's actually related to cor pulmonale when it was first described. And what you really have is some kind of right ventricular or right side of the heart strain. And it's been looked at over and over again over the years and over the decades. And it's not necessarily PE. It might be and it might not be. Could be all kinds of things. Lung injury, pneumothorax, spasm tamponade, maybe even dissection. But PE, maybe or maybe not. But it means something is wrong. So get to the hospital. All right, that should do it for today. Yeah, I'm kind of tired too. But yeah, we need to check our protocol app or even just download the PDF, or you might even have a old loose leaf in your truck. And when you're trying to fall asleep on those 24-hour shifts, pull out some biomedical papers and read them. I've tried to get everything right, but if I got something wrong, please say so. Won't hurt my feelings at all. And if you know a better way, I'd love to hear about it. So here's our references. Again, you can slow down and freeze frame and go look them up yourself.